Ladies and gentlemen, members and guests of the Indonesian Urological Association, I'm Dr. James Simon from Washington, D.C. in the U.S. First and foremost, I'd like to thank the organizing committee for the kind invitation to speak with you today about a subject very near and dear to my heart, titled, "We're Not Doing Enough for the Postmenopausal Vulva and Vagina, and let's look at the evidence." My disclosures are many because I do a lot of drug and device development in all aspects of women's health. None of these disclosures should impact my comments today, and I have references on nearly, if not every, slide. The objectives of my talk today are to make sure that the participant, you, recognize the clinical manifestations of hormone-mediated vestibulodynia, what I'll refer to as VVS, and of genitourinary syndrome of menopause, or GSM, what we used to call vulvar and vaginal atrophy due to menopause, and also to understand the underlying pathophysiology of both of these conditions. Further, I anticipate that participants will appreciate the profound impact that both of these diagnoses, GSM and VVS, have on sexual function, and finally, have a basic understanding of the evidence-based treatment options, including both hormonal and non-hormonal medications and energy-based devices for the management. Some of this information, unfortunately, will be focused on options available in the US. However, I think it will serve as a good example for all of you, even though you don't live or work in the US. Let's start with the embryology and development of the human female vestibule. Recognize that prior to the 9th week of intrauterine gestation, both males and females have female appearances in the genital area. That is to say, even those of us with penises as adults look female in utero. It's only at approximately the 12th week of intrauterine gestation that we differentiate along traditional male-female genitalia lines, with boys developing a penis and girls maintaining the female structure. This is very important as we talk about adult female vestibules and the symptomatology they present with after menopause, although I will also note that many premenopausal women have hormone-mediated vestibulodynia due to low estrogens and androgens, or to long-term use of androgen deprivation treatments, including combination oral contraceptives. Here's the human female vestibule in development. You can see that from the early development, from the neutral, that is to say, intrauterine undifferentiated state, we end up with an adult female vestibule with this area located in reddish brown as the adult female vestibule. What about the male? In the male, the genital structures, as we're well aware, differentiate into the young boy's penis, and the vestibular or vestibule equivalent is the penile urethra. As urologists, I asked you to think about the sensitivity of the adult male penile urethra and whether or not the female vestibule might be equally sensitive under certain biologic circumstances, and in this case, under the circumstances and hormonal milieu present at menopause. Think about it this way. The vagina is not just one structure. It's derived from 3 different tissues, all 3 embryologic layers. The barrel of the vagina is derived from mesoderm, like skeletal muscle, bone, cartilage, and joints, all very tough tissues. And in fact, the epithelium of the vaginal barrel is extremely tough, able to accommodate the stretching of a fetal head during birth. The vulva itself is quite different and derived from ectoderm, mostly skin with hair, and recognize that ectoderm also forms the embryologic basis for not only skin, but for hair, nails, and tooth enamel, nails and tooth enamel being very tough tissues as well. However, the vestibule is derived from embryologic endoderm. This is the same tissue equivalent as the penile urethra, as I've demonstrated, and identical embryologically to the inside of the intestines, the bladder, the stomach, liver, intestines, pancreas, etc., all very delicate tissues, not lending themselves to trauma. Here's the adult female vestibule that I've been discussing. It's where most adult women, menopausal or not, sense their penetrative and contact pain. Androgens are critical to the health, integrity, and toughness of the vestibule, just like they are for the penile urethra. These 2 articles, which I had the great pleasure of participating in, discuss the impact of androgens on genitourinary syndrome of menopause and on both a clinical basis, this first article published in Menopause in 2018, and a matching article discussing the basic research aspects of androgens in the vestibule and for genitourinary syndrome of menopause, published in Sexual Medicine Reviews in that same year. What do we know about treatment of vulvar vestibulodynia, or GSM, or both, in the postmenopausal woman? And by the way, at least in terms of the first bullets, in the premenopausal women. It includes the application of topical estradiol at very low concentrations and testosterone to the vestibule itself twice a day for about 4 weeks, and then reevaluation. There's also a intravaginal treatment for vulvar and vaginal atrophy, which we'll discuss in a moment, DHEA, which becomes estrogen and androgen, estradiol and testosterone, in the tissue of the vagina, and by virtue of its small amount of leakage onto the vestibule from the vagina, can also be used to treat vestibulodynia and hormone-mediated vestibulodynia seen with menopause. While we have few options in terms of treatment systemically with estrogens and androgens, at least in the US, there are no clinical trials looking at systemic estrogen-androgen therapies and their treatment of these conditions, although I suspect in the future there might be. Most recently, Drs. Irwin Goldstein and his wife Sue Goldstein, the current president of the International Society for the Study of Women's Sexual Health, published this article, the first and only one of its kind, demonstrating that the fractional CO2 laser can be used to treat vulvar vestibulodynia and vestibular pain in a group of women similar to those I've already discussed. When one sees such a complicated study design, one needs to take into account that these findings, that is to say that fractional CO2 laser is safe and effective in non-hormonal treatment for vestibular pain, need to be repeated. Too many variables, too much potential for cherry picking of results, but very encouraging for this potential therapy. Let's talk about GSM, or vulvovaginal atrophy. This is a U.S. perspective, but it's an important one, and with many general findings for all around the world. First of all, the population of postmenopausal women is growing. These are the postmenopausal baby boomer generation and subsequent generations. It's estimated that there are 63 million postmenopausal women in the US. I suspect equally or significantly greater numbers present in Indonesia and environs. About 1 in 5 people in the US is actually a postmenopausal woman, and vulvar and vaginal atrophy, or GSM, affects 50% of postmenopausal women at some point in their lives. Recognize that GSM is chronic and progressive without treatment, and it doesn't improve at all without treatment. Many women are unaware that the signs and symptoms of GSM are the result of menopause or their loss of reproductive hormones, which is why we renamed vulvovaginal atrophy as genitourinary syndrome of menopause, GSM, to tie menopause to these symptoms for better patient recognition. As a result of this situation and many others, GSM is both underdiagnosed and undertreated in the US, and I suspect worldwide. This study from a US-based population of midlife women demonstrates that early in menopause, women remain sexually active at age 51.8 years, but by the time they get to be age 62, they are largely sexually inactive. There may be many other reasons for this: loss of a partner, loss of sex drive, but sexual pain with penetration in the vestibule and deep in the vagina are also common reasons for this transition from being sexually active to sexually inactive. It's very apparent from long-term studies, this one from 2009, that hot flashes, night sweats, sleep disturbance, and mood changes, which occur in both the peri and early menopause, are those symptoms thought of by women and many practitioners as being menopausal symptoms, whereas urogenital symptoms, because of their delay from early menopause to mid and later menopause, are often neglected and underdiagnosed and undertreated, as I've suggested. The entire highlighted area here is extremely rich in estrogen receptors. Not only the vulva, vagina, and vestibule, but also the urethra, trigona of the bladder, and surrounding tissues. Important to remember that these are largely estrogen-sensitive tissues, but also, as I've already shown you, to some degree, androgen receptor positive as well. The vaginal histology, as it changes through menopause, is very apparent, and while most of us do not do biopsies, it should be known to each and every one of you that the very thick vaginal epithelium of the premenopausal women becomes thin, friable, and largely avascular in postmenopausal women. That gives us our symptomatology. In addition, loss of glycogen and changes in the vaginal pH as a result probably are equally as important in downstream symptomatology and the changing vaginal biome as are these anatomic changes. On a cellular level, the premenopausal vagina has these large karyopyknotic nuclei containing squamous cells, which are predominant in the premenopausal woman. They become uncommon and largely replaced with parabasilar cells, large nuclei, very little, relatively very little cytoplasm, and an increase in polymorphs, white cells, as a result of that biome change I've already mentioned. Here's a representation of just what happens. In the premenopausal woman, superficial cells represent about 15% of the total, whereas parabasilar cells about 5%. In the postmenopausal woman, the superficial cells decrease to about 1%, and the parabasilar cells increase to about 40%, just shy of 40%. These changes are very characteristic and can be used in the office or laboratory to make a diagnosis, but I would prefer everyone be able to recognize this on sight or by symptoms alone. Another way of assessing these changes due to hormonal decrement after menopause is to use pH paper and check the vaginal pH, recognizing that in the premenopausal woman, the normal vaginal pH is 4.5 to 5, changing only during the time of ovulation to accommodate the very low, increasing the very low pH to accommodate the higher pH needs of the sperm. But during menopause, with estrogen loss, the pH becomes 6.5 to 7, just as it was during ovulation, but is a chronic state which becomes rife for increased colonization of bacteria, fungi, and viruses. Recognize that this very low pH is in fact antiseptic in the premenopausal and postmenopausal but estrogenized vagina. As I said, be able to recognize it when you see it. This cartoon, generously given to me by Murray Friedman, shows the premenopausal vulva and vagina here, the earlier postmenopausal vagina here, and the largely unusable, typically quite painful late postmenopausal vagina here. I'll show you examples from real patients. Here's one, a premenopausal appearing vagina in a 65-year-old woman who's using estrogen therapy. This is topical estrogen therapy. She discontinued estrogens 3 years previously, and her vagina ended up like this, still potentially patent, but very atrophic, restricted, pale, and significantly smaller. Progression continues such that the vaginal opening, as noted here, becomes almost the same size as the urethra in this severe case of GSM. And then finally, in this case, the urethra is actually larger than the vagina, which is now actually closed, completely adherent and closed, incapable of penetration of any sort. What are the goals of treatment for GSM? They include to relieve symptoms, reverse those anatomic changes I just showed you, and hopefully improve sexual function if desired, and improved quality of life, as women with GSM not only have painful sexual function, but also may have dryness or pain just sitting and at rest. Vaginal atrophy and sexual function have been studied together, and this study, an older one now from Levine et al., demonstrates that vulvar and vaginal atrophy is correlated with sexual function, with women having four-fold greater likelihood of sexual dysfunction if they also have vulvar and vaginal atrophy, both anatomically diagnosed and symptomatically diagnosed. There are a number of non-prescription treatments for GSM. They broadly fall into moisturizers and lubricants. Moisturizers are used long-term on a regular basis, whether or not women are actually engaged in sexual activity or not. They maintain vaginal hydration and relieve primarily symptoms of dryness because they are hydrophilic compounds drawing water into the vaginal canal and providing moisture. Lubricants, on the other hand, are used as needed during sexual contact, and they moisten both the vaginal, vulvar, and barrel of the vagina. They come in both short-term and long-term versions, that is to say, those that last a short duration and may need reapplication during prolonged activity. Those are typically water-based lubricants. Longer-acting lubricants are typically silicone-based lubricants. They're slightly more expensive but last a long time. In addition, there are oil-based lubricants and hybrids of all three of these, water, silicone, and or oil, which are meant to give that lubricant characteristics that are both short and long in duration. We use lubricants in our genital exams all the time. Why wouldn't we encourage our patients to use them during sexual contact as well? There are some additional effects of estrogen that are both prosexual and important for vulvar, vestibular, and vaginal normal physiology. They're listed for you here. I won't go through them one at a time, but two that you might not appreciate are improved sensory perception, including those needed for sexual arousal, like vibratory stimulation, and changes in the vaginal vault itself, like increasing vaginal elasticity, collagen content, and vault size. We have a number of estrogen and non-estrogenic treatments approved in the U.S. for treating vulvar and vaginal atrophy due to menopause. They're listed here. You may or may not have them in Indonesia and surrounding environs. I will make some general comments about them. They're all approved by the FDA. They all have similar, although not identical, labels, and they all work equally well in terms of treating symptoms of vulvar and vaginal atrophy. There are literally no head-to-head randomized trials of these agents in the US. Ospemifene is a selective estrogen receptor modulator, or SERM, sometimes called an estrogen receptor agonist-antagonist, and it binds to primarily the ER alpha receptor, but also to ER beta, giving it different effects in different tissues. It's largely estrogenic in the vulva and vagina, and largely anti-estrogenic in the endometrium and in the breast. It's an oral once daily pill. It's been documented to reduce sexual pain. Here's dyspareunia, decreased by 12 weeks in 2 identical randomized placebo-controlled clinical trials. In addition, this product is now FDA approved for treating vaginal dryness unrelated to sexual activity. And here's one of the publications documenting that effect. It's also been shown, by virtue of its impact on both tissues and pain, to reduce sexual problems. This publication demonstrates that ospemifene was able, in the context of women treated for GSM, to improve sexual desire, arousal, lubrication, orgasm, satisfaction, and reduce pain, all by just 12 weeks' time. This publication demonstrates that this preparation, ospemifene, can reduce breast cancer recurrence when used to treat vulvovaginal atrophy or GSM symptoms in individuals with breast cancer or breast cancer survivors. The reference from 2020 is appended here. Vaginal DHEA, which in our country is called intrarosa, works by a process known as intracrinology, not endocrinology, but intracrinology, and I'll talk to you about it now. Endocrinology is where an endocrine gland produces a substance that goes to a different site through the blood vessels. Paracrine or paracrinology is where a compound is produced by an adjacent cell that then modulates an effect in the cells nearby. Autocrine effects are where a cell secretes or produces a substance that then acts on itself, autocrine, and in the case of intracrine, the cell takes up a substance, produces a substance intracellularly, and then it acts on the cell itself. It is that intracrinology that we believe is how DHEA affects cells of the vulva, vestibule, and possibly vagina when applied intravaginally. Prasterone or DHEA becomes estradiol and testosterone in the vaginal barrel. However, these are endometrial biopsies demonstrating that those effects of estradiol in the vulva or in the vestibule and vagina do not extend to the endometrium. In women with GSM, or VVA. This product was able to show, similar to the study I presented recently, an improvement in desire, arousal, lubrication, orgasm, sexual satisfaction, and decreased sexual pain, just as I demonstrated for you with ospemifene. One of the examples I'd like to give you is a product that you may not have in Indonesia. It's called Imvexi. My point here is that as low as 4 micrograms of estradiol per day for 2 weeks, followed by 4 micrograms as infrequently as twice weekly, was able to increase superficial cells, decrease parabasilar cells, and reduce vaginal pH, and lead to improvement in vulvar vaginal atrophy pain symptoms, getting to FDA approval. 4 micrograms twice weekly, demonstrating just how sensitive vulvar vaginal and vestibular tissues can be following menopause. And this just shows how that 4 microgram dose in the upwardly pointing triangles can reduce dyspareunia severity over as short as 12 weeks duration. The Journal of Clinical Oncology, reporting for the practice guidelines from the Canadian Cancer or a Clinical Oncology Society, chose 2 products for use in the treatment of introital pain and dyspareunia in women with breast cancer on aromatase inhibitors. Those 2 treatments were ospemifene and vaginal DHEA, which I've mentioned both, and their sexual effects as well. I just want to emphasize what I said about this 4 microgram dose, that is to say very low doses of any product, whether it's Imvexi or even 10 micrograms of Vagifem, a vaginal tablet, or 7.5 micrograms of estradiol from an estradiol vaginal ring, which I'm not going to discuss. But in short, all those products deliver an annual maximum dose under 3 milligrams a year. That's different from both the vaginal estrogen creams and also systemic therapies. So they can be used very safely in women with fears of estrogen treatment or relative contraindications to estradiol vaginal treatment. I don't want to minimize the importance of vaginal dilator treatment because it's critical to our treatment of those women with vaginal or vestibular stenosis, vaginal agglutination, and insertional dyspareunia. Here's a nice image of some silicone dilators, but dilators with associated physical therapy can be very helpful in establishing normal anatomy once the hormonal treatments have started and during their long-term, remember these are chronic and progressive conditions, long-term treatment. A word about energy-based alternatives, and first to document that at least in the US, the process for FDA clearance, that is for devices, and FDA approval for drugs are very, very different, and for drugs are much more rigorous than for devices. The fractional CO2 laser can be used for treating vulvovaginal atrophy and GSM. This is an example of one of the better studies. There are now many of them, randomized studies looking at visual analog scales for symptoms, vaginal pain, burning, itching, dryness, dyspareunia, dysuria, etc., and objective endpoints, change in the vaginal health index, vaginal wall elasticity by using dilators and determining the tolerability of dilators, changes in the female sexual function index, etc. Here's that same study documenting that women can increase their vaginal elasticity following CO2 laser treatment of the barrel of the vagina and the vestibule. Further, female sexual function index scores were statistically and significantly improved. Women's sexual satisfaction and satisfaction with the treatment was very high. 96% were either very satisfied or satisfied, and 73% reported that their symptoms were better or much better at 3 months of follow-up following treatment. The pros of vaginal fractional CO2 treatment are: it's good for patients for whom estrogen is absolutely contraindicated. It solves poor compliance or adherence with vaginal estrogen treatment. It's safe, simple, and basically painless with topical analgesia for the vestibule. Very few adverse events have been reported. The cons are that there are no pH changes, therefore it's not physiologic in that regard, does not affect dysuria or vaginal laxity symptoms, and that there are conflicting data regarding the number of treatments necessary to show improvement and the number of follow-up treatments needed to maintain benefit in those who have benefit. It's expensive in the US, and potential ongoing treatments are required. Many larger randomized sham-controlled trials may be needed to garner benefit and more universal acceptance. There is this study, it's an important one, published in 2021 in JAMA, which failed to show benefit of this treatment. There are several methodologic problems with this study, but in issues of fair balance, it should be known to you that this study stands above many in demonstrating lack of an effect of the CO2 laser for exactly the treatment that I just demonstrated benefit. And finally, there are a number of controversies which I won't take you through related to the benefit of CO2 laser or not. Does it work or doesn't it? But here's a systematic review and meta-analysis evaluating those issues. Regardless, treatment of vulvar and vaginal atrophy due to menopause and the downstream biome effects of low estrogen has now become a urogynecological issue, one that many of us who have practiced in this field have known about for decades. This is the American Urogynecological Society special issue submission from 2021 documenting that vaginal estrogen is first-line therapy for recurrent urinary tract infections in postmenopausal women. Data on estriol not available in the US, has been demonstrated this phenomenon, that is a reduction in recurrent urinary tract infections, could be a treatment, and that's been known for at least 20 years. So in summary, under low estrogen conditions, like those in menopause, the vagina becomes shorter, narrower, less elastic, and more prone to injury. The vaginal epithelium thins, becomes less rugated, cracks, less vascular, and less elastic. The labia minora thin, become shorter, less vascular, and more likely to disappear. The clitoris regresses, becomes smaller, less vascular, and less sensitive. The vaginal pH rises. The local environment becomes more basic and more likely to be colonized with fungi and coliforms. The shortened urethra, in proximity to those vaginal coliforms and increased vaginal pH, lead to an increased risk of asymptomatic bacteriuria and urinary tract infections. And the vestibule, which I've focused on here, becomes thinner, more sensitive to pain, as those nerve fibers close to the surface epithelium become more prominent and thereby less desensitized or more sensitive. The vestibular glands themselves demonstrate signs of inflammation and are associated with pain. As a consequence of all these, touch, whether sexual or not, can become unpleasant if not painful. Penetrating vaginal sex becomes unpleasant if not painful or impossible. Arousal and orgasm become muted or impossible, and sexual activity ceases, as I've demonstrated. Anxiety and depression, including major depressive disorder, can actually accompany those psychosocial sexual changes. So in conclusion, while GSM and VVA are both natural signs of aging and compatible biologically to those evolutionarily advantageous seen during lactation, GSM and VVA has an adverse effect on genital urinary health, on sexuality, on relationships, on quality of life, but is both preventable and a treatable disorder. The NAMS, now called the Menopause Society, the North American Menopause Society, 2020 Genital Urinary Syndrome of Menopause position statement is consistent with my comments to you here today, and I had the good fortune of participating in its writing and approval. So remember, for the vulva and vagina after menopause, pink and plump, not pale and frail, should be our operating principles. Thank you, and we'll have a separate live Q&A session. I appreciate your attention. Have a great day.